Oncology. Today we have a talk to from none other than Dr. Kinjal Jani. He's the Director and Head of Department of Radiation Oncology at the HCG Cancer Center, Ahmedabad, a very renowned radiation oncologist. As you see, we always say that now the cancers don't ever follow the rules of Halstadian rules. This was the concept which came. Now we know it is not the Halstadian but the Fisher hypothesis. The old concept of surgery starting in the primary area, then slowly having a continuous contiguous spread, then lymphatic access, then lymph node, then blood, then systemic mats. In oncology, this rule is never followed. But there are still exceptions. Squamous cell cancer of the oral cavity, squamous cell carcinoma of the penis, squamous cell carcinoma of the vulva still follows the Halstadian concept. In oral cavity squamous, without a regional node, you will never have a systemic disease. That's why a good loco-regional control in head and neck cancer, how much ever advanced they are, stage 4A, stage 3 or stage 4B, can translate into a cure. And how is it achieved? Good surgery alone will not do. The excellent modality is radiation oncology. So radiation oncology is one of the main reasons in head and neck cancer, loco-regional control and cure has been achieved. But it came at a cost of destroying the salivary gland and long-lasting thyroid destroying and side effect. But with now modern era of VMAT, IGRT, IMRT, breath holding, various techniques, SBRT, this has changed. So the advancement that happened in head and neck radiation is phenomenal, achieving great cure rate, excellent loco-regional control with minimal side effects. So to hear more about it, we have Dr. Kinjal. Thank you, Kinjal, for accepting our invitation, and welcome, and over to you.
Thank you so much, sir. Thank you so much to Somshekhar sir and Kaustubh sir for giving me this opportunity to talk to surgical students and radiation students also about how we have evolved. And rightly mentioned by you that we all have evolved. We have evolved in the field of surgical oncology. We have evolved in the field of radiation oncology. And first of all, I'd like to thank my colleagues, Maitri and Samir, because they are the ones who help me, and we right now have two machines at our place. We have a true beam machine and we have a turbotherapy machine, which are like state-of-the-art machines at our place. Now, when you talk about cancer, it's a teamwork. It's a teamwork, as rightly mentioned by you. It's a teamwork. Not even a surgeon can cure a cancer. Not even a radiation oncologist can cure cancer. So we all need to work together, and we need to make sure that we plan a teamwork. MDTs are very important in the field of oncology nowadays. That we need to have a surgeon, the medical oncologist, the pathologist, the radiation oncologist. All are required. And it's a teamwork, and at the end of the day, we all aim for the outcome of the patients. So, to talk about radiotherapy. What is radiotherapy? It's a treatment of tumors with ionizing radiation. What is ionizing radiation? These are the X-rays. Like what we used to do was we used to use cobalt machines earlier, and they were gamma rays, and then eventually we evolved from gamma rays to high energy X-rays. So basically it is a treatment of tumors with ionizing radiation, and we have evolved from cobalt to linear accelerators, and nowadays we do a lot of newer techniques like IMRT and IGRT, as rightly mentioned by you. Basically, any cancer treatment is usually done by three things: a surgical knife, radiation, and the chemotherapy, chemo or the immunotherapy. So generally, we treat patients with either of the three techniques, or a combination of all three techniques: surgery, chemotherapy, and radiotherapy. So when we talk about cancer in head and neck, this is the red line. Anything anterior to that like oral cavity or salivary glands, we prefer to do a surgery first. Anything posterior to the red line, we would prefer doing radiotherapy. So we play a major role in the management of head and neck cancers, either adjuvant to surgery or as a radical radiotherapy. We play a major role because all tumors which are posterior, generally we treat these patients with radiotherapy. Now this is a very old machine. This was developed in 1950s. It's a cobalt machine. I think the young generation would not have seen this machine, but Dr. Somashekar and Dr. Kaustubh would have seen this machine. It's a cobalt machine. We had this machine in 1950s, and then we have evolved from there. In 1970s, we came up with this block. You can see here. We started using the blocks. So what happens? Earlier we used to treat a square field. But then in 1970s we started using these blocks so that we can spare a particular area of the field. That is all we started. That is called a cerebral blocking. We started that in 1970s. In the 80s came 3D treatment. So where we had this multi-leaf collimator. It is called MLC. Multi-leaf collimators, where we started blocking a particular area so that we don't treat only the square area, but we can do a targeted radiotherapy according to the shape of the tumor. So this is all we started in 1980s. In 90s came IMRT. Now this is a word which is very familiar to all of us, IMRT. This word, IMRT, where we can do intensity modulated radiotherapy, where we have started sparing the normal tissues and we have been able to focus on the tumor area so that the normal tissues are spared, so the side effects are less, and you do targeted radiotherapy. That is what we started. And in 2000s came the high resolution IMRT and IGRT. Now what is IMRT IGRT? Now this was the first machine of IGRT, image guided radiotherapy, where you do IMRT. The treatment is IMRT, where you give a very high intense radiotherapy to the patient, but at the same time you make sure you hit the right place. So what happens in IGRT is you make sure you hit the right place and then only you target. So it is nothing but IMRT, but with image guidance. So this we started in 2006. Now this is one of the newer tools we have. It's called a cyber knife, which we started in 2008 in HCG Bangalore and Apollo Chennai. This is a radiosurgery tool where we do surgery with radiation. So you guys can imagine, you guys being surgeons, you can imagine we do surgery with radiation and we give a very high dose of radiosurgery and we treat those tumors. So this is something which started in 2008. That is called radiosurgery with cyber knife. And in 2010, we came up with this machine called tomotherapy, which we have it at our place right now. This is the machine which was first installed in Tata Memorial Hospital, and then at multiple places in India. Now this machine looks like a CT scan. So we treat patients in a helical way. So that the dose to the normal tissue can be significantly reduced. So this was a newer advancement of radiotherapy. And in 2019 came the proton beam therapy. Now this is available at two places in India, one at Chennai and one at Tata Mumbai, Kharghar Center. Now this is a machine which can deliver a very high dose of radiotherapy to a particular target and spare the normal tissues. So again, a newer advancement. So whatever you have seen in last 7-8 slides is only about the advancement of radiotherapy in sparing the normal tissues. So I'll just go back again. So this all, whatever we have, is just to spare the dose to the normal tissues, so that we have a targeted radiotherapy and we don't give a high dose to the normal structures. Nothing has improved. As far as the outcome is concerned, it is only about the side effects. So the way we have evolved in the field of radiotherapy is basically for normal tissues. So we are trying to spare the normal tissues and do a lot of targeted radiotherapy. Now, where do we give radiotherapy? We give it for malignancy also, and we give it for normal structure also, benign structure also. So there are a lot of brain tumors where we do a lot of benign radiotherapy, like pituitary adenoma, acoustic schwannoma, and meningiomas. Lot of so we do it for malignancy also, and we do it for benign structures also. We do it as a external beam radiotherapy and brachytherapy. Now brachytherapy, I'll just brush up on brachytherapy. What is brachytherapy? It's a treatment of tumors. What does brachy mean? Brachy means close to tumor. So there is a tumor in tongue, or there is a tumor in buccal mucosa, where we put needles and we give a high dose of radiotherapy to that particular area with those needles. So there is a source called iridium, or we used to have it cobalt earlier, that goes into that particular channel and treat a particular area. So routinely 99% of our patients are treated by external beam radiotherapy, but there are a few patients which we can treat with brachytherapy, where we put these needles and we give high dose of radiotherapy with a particular source. Now then there is a radical radiotherapy. As I showed you the red line. Anything posterior to the red line, we give radical radiotherapy, and anything anterior to that red line, we give adjuvant radiotherapy. So there is a role of radiotherapy for all head and neck cancers. Whether it's a T1 tumor, T2 tumor, T3 tumor, or T4 tumor, we have a role to play. As rightly mentioned by Dr. Kaustubh and Dr. Somsekhar, that not only surgery can cure any head and neck cancer. We need to have a combination. We need to have a multidisciplinary team where we decide whether this patient requires radical radiotherapy with or without chemotherapy, or adjuvant radiotherapy after surgery. So we need to be very, very clear whether this patient goes for a radical radiotherapy or goes for a adjuvant radiotherapy. And the concept of concurrent chemoradiotherapy plays a big role. So what does chemotherapy do to radiotherapy? So you cure a tumor either with surgery or with radiotherapy, but chemo plays a role in supplementing to the radiotherapy. It's a mild dose of chemotherapy which is given along with radiotherapy to make sure that the radiotherapy works well and the efficacy of radiotherapy gets better. So we do a lot of concurrent chemoradiotherapy for radical tumors of base of tongue, nasopharynx or hypopharynx and everything. and the dose of chemotherapy is mild, where we don't have the hair loss and all. So we work together. And there is a role of palliative radiotherapy. A patient has failed, a patient of buccal mucosa or a tongue has failed after the curative treatment into a particular site, and we give a palliative radiotherapy for two things, basically for two things. One is for palliation for pain, and the second is for hemostasis. So any tumor which is a fungating tumor in the buccal mucosa or tongue which is like having a lot of bleeding, we do give palliative radiotherapy. We give like 5 to 10 sittings and we relieve them from symptoms. So there is a role of radiotherapy in a palliative setting also to relieve the patients from symptoms or from pain or from bleeding. These are the two most common indications of palliative radiotherapy. So these are the sites where we give radiotherapy. Now, whenever we treat any tumor of the body, our aim is to have the highest loco-regional control. We want to have the function preservation. So I'll not go into the details, but yes, like rectum, it's a tumor of rectum. We want to spare the. We don't want the patient to develop have a colostomy. So we want to have a function preservation, and we want to have the minimal morbidity as possible. So we try to treat patients with one treatment, maximum by 2 treatment. We don't want them to be treated by 3 treatment. We know we have 3 treatments: surgery, chemotherapy, radiotherapy. So we want these patients to be treated with a single modality, either with surgery or radiotherapy, or a combination of therapy. So generally what happens is for a stage 1 or a stage 2 tumor of any head and neck site, we want to treat with a single modality, either with surgery. So if it is oral cavity or salivary gland tumors, we want to treat those with surgery, and anything beyond, like a nasopharynx, oropharynx, hypopharynx or a larynx, we want to treat this patient with radiotherapy, but a single modality. We don't want to add 2 things. For a stage 3 and a stage 4 tumor, we would want a combined modality. So we go for a surgery followed by radiotherapy, or we go for a surgery followed by chemoradiation, or we go for concurrent chemoradiotherapy. So it all depends on a particular site and particular stage how we treat those patients. So for an early stage, it's a single modality. For an advanced stage, it's a combination of treatment where you need to treat these patients with 2 or 3 modalities. So these are the sites where the role of radiotherapy is there. So for a nasopharynx, PNS tumors, oral cavity, salivary glands, oropharynx, hypopharynx, larynx, or MUO, where there is a metastasis of unknown origin, our role comes into picture. For oral cavity, for a salivary gland, you go for surgery first. For the rest of the site, like nasopharynx, hypopharynx, oropharynx, larynx, we go for radiotherapy upfront. And for a tumor like metastasis of unknown origin, we need to have a tumor board discussion. We need to discuss and decide if there is a small node in the neck. You do the neck dissection first, followed by curative CTRT. If it is an inoperable neck node, you go for chemotherapy followed by chemoradiotherapy. So everything depends on a particular site and particular tumor stage. So we need to have a discussion amongst the surgeons, the medical oncologists and the radiation oncologists, and decide the plan of management. So not everybody goes for the same treatment. Everybody has a different treatment. So the importance of MDT, multidisciplinary team, is very important for head and neck cancer treatment. I would say for all cancers. So we need to sit together along with the surgeons, along with the radiation oncologists and the medical oncologists, and decide the plan of management. Now let us talk about the adjuvant treatment. When, like you guys being the surgeons, when do you send patients to us for adjuvant radiotherapy? Wherever the tumor is large. For head and neck, more than 4 centimeters. Any tumor which is large, you send those patients for adjuvant radiotherapy. Whenever there is a depth of invasion more than 6 millimeters, 7 millimeters, 8 millimeters, you send these patients for adjuvant radiotherapy. Whenever there is a node positive, you send for radiotherapy. Node with a perinodal extension is an indication for chemotherapy along with radiotherapy. So we need to think about chemo plus radiation for a patient who has a node positive. Honestly, no surgical oncologist has a close or a positive margin. But if it is there, you need to think about adjuvant radiotherapy. Any tumor with a poorly differentiated tumor or a positive perineural invasion, we need to think about adjuvant radiotherapy. So these are all the indications of adjuvant radiotherapy, where we have to think, being surgeons, you operate, and if these are the features, you have to send this patient for radiotherapy. So no particular modality can cure a cancer. It has to be a teamwork. So let me go to nasopharynx. I'll just show you here. So generally for a nasopharynx, we give a radical radiotherapy. As you can see here, this is the tumor, which we treat with radiotherapy usually. And you can see there is a significant response after it's a day 1 and a day 17. So these are the tumors which melt with radiotherapy. And we need to make sure that we need to do a replanning. So what happens during radiotherapy, there is a change happening in the tumor site. So we need to do a replanning. That is also very important, that we change our target. So if this is a tumor and there is a significant response like this and like this, we need to do a replanning. Just like you surgeons, we also need to change our plan. Now, let us talk about the PNS area. So, paranasal sinus is one of the sites where surgery and radiotherapy both plays a very important role. There are not very well trained surgeons who do a good skull base surgery. So surgery plays a very important role, and radiotherapy also plays a very important role, because we don't have surgeons everywhere who do a good paranasal sinus surgery. Fortunately for me, we have Pareen at our team and Nitin at our team. They do a wonderful job operating paranasal sinus tumors, but it's not everybody's cup of tea. So paranasal sinus is one of the areas where these are the sites: maxillary sinus, ethmoid sinus, sphenoid sinus. These are the areas radiotherapy plays a very important role. Now what happens with conventional radiotherapy? So when we used to treat patients with conventional radiotherapy, we used to treat parotids and the spinal cord. So we used to see a lot of side effects. Because of parotid, dryness of mouth. Because of spinal cord, Herbite syndrome, where we used to suffer a lot managing patient side effects. But with IMRT, this is something which we used to do. You can see here, majority of you might not have seen this. Dr. Somshekhar and Dr. Kaustubh must have seen. We used to treat patient like this. So everything from here to here would get the same amount of radiation dose, and there will be a lot of side effects. So these are the acute complications of radiotherapy: mucositis, odynophagia, dysphagia, hoarseness of voice, weight loss because patients cannot eat, skin reaction, dermatitis, discoloration, dryness, and epilation of the field, nausea, vomiting, lot of side effects. So these are the acute side effects of radiotherapy, and these are the late complications. Now this is something which we can control. So whenever the patient used to have late complications, I'm talking about the older days, xerostomia, subcutaneous fibrosis, esophageal stenosis, dewlap, having a swelling at the submental region, Hermite syndrome, which has become rare nowadays, but it was very common, osteoradionecrosis. I don't agree with the term osteoradionecrosis. I would say radionecrosis of mandible, a lot of trismus because of submucous fibrosis. So these are all late complications of radiotherapy. Now, this is something which we can control. The acute complications we cannot control because it is given to the particular area and the patients have that particular side effects. But these are the things which can be spared. We can spare the xerostomia, we can spare the subcutaneous fibrosis, we can spare the dewlap, we can spare all this particular side effects. But your radiotherapy field must be in such a way that you spare the normal tissues. Now these are the acute complications. I am sorry that I've added cystitis and proctitis also in my slide, but for head and neck we see a lot of mucositis like this, which is acute mucositis. Then there is a xerostomia, dental caries. So for dental caries, what we do is we send our patients for dental care before we start their radiotherapy, so that they don't develop late complications like dental caries. Cataract is very common for a PNS tumor. We tell the patient that you are going to develop cataract because the tumor is very close to eyes, and the tolerance of lens is very less compared to optic nerves and optic chiasm. So for us, sparing optic nerve and optic chiasm is easy compared to lens. So this is a very common side effect of tumors which we treat with radiotherapy for a PNS area. To prevent late complications, we have had a lot of options. So we used to treat patients with amifostine. This was a drug which used to reduce the complications of xerostomia. Nowadays we have a drug called pilocarpine. Pilocarpine significantly reduces xerostomia. We give it to majority of our patients because what happens when we treat a head and neck area, we don't spare the SMGs. Because it's a very high chance that we have a level 1B node. So we don't try to spare SMGs. So what happens, we spare the parotids and we don't spare the SMGs. So it's a very common side effect of radiotherapy that we develop, these patients develop xerostomia. So we prescribe pilocarpine. And we do have a lot of techniques like, as you can see in red, we have a technique called 3D conformal radiotherapy, IMRT, IGRT, rapid art tomotherapy, where we can avoid the dose to the normal tissues and the side effects can be significantly reduced. But still, SMGs cannot be spared. So our patients will develop some amount of xerostomia. So we need to take care of that. So we usually manage it with xerostomia. What is IMRT? What is IMRT? So just to make it very clear to you all surgeons, it's a targeted radiotherapy. It's a precise treatment where we give a high dose to target and spare the normal tissues. With that, we can go for a high dose of radiotherapy to, like for example, we have a tumor in base of tongue and we want to go for a high dose. We can have a higher cure rates and we can have the less side effects. So with IMRT, we can do targeted radiotherapy and spare the normal tissues. But at the same time, we are not sure whether we hit the right place or not. Because if you give a high dose of radiotherapy and you are not sure whether you hit the right place or not, we don't know what happens. For the accuracy, we have the technique called IGRT. That is called image guided radiation therapy. We do it because of setup error, because every day patient cannot lie in the exact same position. There may be intra and interfraction movement. There may be change in the target and normal tissues. With IGRT, you can do a daily verification and you can do accurate treatment delivery. You can deliver proper radiotherapy dose with perfect precision. So for that, we need IGRT. Now this is the steps. What we do. So I'll just take you through the steps. So what we do for radiotherapy is we prepare a mask like this. So these kinds of masks keeps the patient in the exact same position every day for the radiation delivery. So first of all, we do this mask preparation. Then with the mask preparation, we do a CT scan of that particular patient. And we decide the area to be treated. So sometimes for a base of tongue, we do an MRI also. As you can see here, for a base of tongue or for a tongue or for a nasopharynx, we do an MR. But otherwise, generally we do a CT scan where we decide our target. So this is an example of a PNS tumor where we have done an MR and a CT and we have drawn our target where we decide which area needs to be treated. Again, sometimes we do a PET CT fusion. So like, you can see here for a base of tongue tumor, you can see a tumor here and it is not matching here. There is some mismatch here. So on a CT you do it like this. On a PET, you cannot match it completely. So sometimes we need to do a PET CT fusion also. Again, seen here, it's a posterior pharyngeal wall tumor. And you cannot match it perfectly, but on a PET CT, you can match it perfectly, as you can see it here. So we take help from a CT scan or an MRI or a PET CT for our planning. Now this is something which we used to do. We used to give one radiation from here, bilaterally, and there were a lot of complications because we used to target the normal tissues also. But nowadays we do something like this. This is called an IMRT or an IGRT field where we spare the parotids and the spinal cord. So we do a lot of focused radiotherapy. So these both are examples of oropharynx tumors. And you can spare the normal tissues here and we could not spare it in the old days. Now these are the tumors, like you talk about the paranasal sinus tumors. This is optic chiasma, this is the retina, and these are the lens. And you treat this kind of tumors. Now this was not possible in 1990s, but But nowadays, with focused radiotherapy, it is possible to treat a paranasal tumor, sparing the retina, lens, and optic nerve, optic chiasma. So this is something which we have evolved. Now this is something which is very important, which we do is this is an oropharynx tumor. It's an oropharynx tumor where we are giving a very high dose of radiotherapy to that particular area, and we are treating the rest of the area also where the tumor can spread, and we are able to give a high dose to that particular area and the surrounding area, sparing the normal tissues. Now this is something which is very important. Why do we do IGRT? You can see this image. You can see this image. You can see the image. This is an image of a particular patient. Every day there is a variation. There is a variation every day. So now if you do an IMRT, you do a targeted radiotherapy and you are not able to spare the normal tissues, it's of no use. So we do image guided radiotherapy and we focus it and then we target it. So this is an example of IGRT, image guided radiation therapy. I'll not go into details of this, but tomotherapy, the machine which we have at our place, it's a good machine where we can give a large field radiotherapy and we can treat multiple targets at a place and we can do a re-radiotherapy. I'll not go into this detail. So what are the cares required before and during radiotherapy for head and neck cancers? We need to make sure about the oral hygiene. We usually prescribe fluoride toothpaste, soft toothbrush and frequent mouth gargles to our patients. We do extraction of teeth with caries 2 to 3 weeks before radiotherapy. So majority of the times our surgeons do it at the time of surgery, and if there are radical cases like a base of tongue tumor or a soft palate case or a hypopharynx case, we do it a couple of weeks before we start the radiotherapy. We avoid tooth extraction during at least 18 months post starting. It is 12 months, but generally we keep it for 18 months. We don't want to do any extraction for 1.5 years. We advise our patient to do plenty of fluids. They should maintain their nutrition. Cessation of tobacco and smoking is very important. And we do bile tube insertion or a gastrostomy before we start radiotherapy. PEG is very common in Western world. It's not that common in India. So generally in India we prefer bile tube, and in US, in the Western world, they prefer PEG tube. But it depends on a treating physician. How do you want to maintain their nutrition? So these are very important points: the oral hygiene, the nutrition, and the physiotherapy. These are very, very important things. So to conclude, radiotherapy is an integral part of management of head and neck malignancies, and we treat our patient with IMRT and IGRT nowadays. So we don't do conformal radiotherapy or old techniques. We always treat our patient with IMRT or IGRT, which is accurate and precise, so that we can reduce the dose to the surrounding tissues and we can go to higher dose, so that we can have a higher tumor control, we can have a better conformity, and we can reduce the late complications. Acute complications are usually same because the area which we treat, patients are going to develop acute complications, but we need to make sure that the patient's nutrition and oral care are taken care of during head and neck radiotherapy. And tomotherapy and proton beam therapy are the newer techniques where we can give very focused radiation and sparing the normal tissues. So with this, I would just like to end and say thank you to all, and I am ready for any questions you have, sir.
Yeah, thank you, Dr. Kinjal. So, trainees, if you have any questions, comments, you may type in the chat box. Thank you.
It takes around 5 minutes for radiotherapy. So generally it takes, the session lasts for around 5 minutes only. Hemostatic RT is basically for patients who bleed, like very advanced tumor having bleeding from oral cavity, uh, you know, tongue, buccal mucosa. So these are the areas where we give hemostatic RT. Generally, we prefer avoiding palliative RT, but yeah, we do give hemostatic RT for patients with bleeding and all. Okay, there is a question, what is the difference between IGRT, IGMT and VMAT? So IMRT is basically the technique, IMRT, that is called intensity modulated radiotherapy. And IMRT has a better version called VMAT, volumetric arc therapy. So IMRT used to take around 15 minutes for radiotherapy and VMAT takes only 5 minutes. IGRT is just targeting and shooting. So the basic technique is IMRT or VMAT, and it is we are targeting it with image guidance. So what is the extra benefit of IGRT than IMRT? So IGRT, we see and we target. So I have a gun, I want to shoot a person. I may hit his heart, I may not. So with IGRT, I am pretty sure that I will hit his heart. So advantage of IGRT is that you see and then you deliver. So basic technique is IMRT only, but it is with image guidance so that you see and you target. Futures of this machine, yeah, a lot of new machines are coming up. Honestly, if you talk about VMAT or a tomotherapy or a proton therapy, not too much of difference. Honestly, not too much of difference. These all machines are very focused machines where we give radiation to a particular target and we spare the normal tissues. So it's not too much of difference, but yeah, there is a 2 to 5% difference in sparing the normal tissues.
Dr. Kinjal, can you give a few words about carbon therapy?
Carbon is something, that is something which we should talk about. Carbon ion therapy. Carbon is something which is not available in India. Carbon is available in Japan, Germany, US. So carbon is more potent compared to X-rays, what we routinely treat with. So carbon is better than the X-rays which we treat or proton. So the efficacy of carbon is 4 times higher than X-rays and protons.
So does this mean that the fractions will reduce also?
Absolutely. We don't need to give. So, sir, what happens? We usually give 60 to 70 gray. If we have carbon, we can treat this patient with 40 gray. So the dose can go down. Because they are more potent. it is less likely to come in India because the cost of proton is 500 to 600 crores. So you can imagine that getting a carbon to India will be very tough.
There is one more question. It says radiation for recurrent cancers.
So for a recurrent cancer, the ideal treatment is surgery. And if the surgery is not possible, we can go for a re-RT at least 1 year post previous RT. At the same time, if the patient is operated for a recurrent cancer, we do go for a adjuvant re-RT. Again, we need to wait for at least 1 year to go for a re-RT.
So in head and neck, how many times you can give radiation? Say a patient has a recurrence and then there is a second malignancy for which also to be treated, and there can be a third malignancy also. They may be 2 years apart or 3 years apart. How many times you can give radiation? Is there a ceiling to that?
No guidelines or no guidelines for that particular thing. But basically, so honestly for me, I have treated a patient for 4 times. I have treated a particular patient for 4 times, but again it all depends on the duration of second malignancy or a recurrence. It all depends on that. So no particular things how much time we can treat or we cannot treat. But maximum time I have treated is 4 times a particular patient for different malignancies.
And any particular tips apart from dental hygiene and dental prophylaxis to prevent osteoradionecrosis?
Nothing, sir. Nothing. It's a unfortunate thing for the patients having a ORN. So it is. See, basically, it does not depend on. Honestly, it does not depend on radiotherapy. A patient who might develop ORN may not be given a high dose to that particular bone, and a patient who does not develop ORN may be given a very high dose to that particular bone. So there is nothing in guidelines that if you give that particular dose and the patient develops ORN or not. So it's a fate of the patient, honestly.
So there are a few more questions. What is SBRT?
SBRT is it's called stereotactic body radiotherapy, where we give a very high dose of radiation to a particular area. So SBRT for head and neck plays a role in a tumor which has failed. So if I have treated a patient for a CA tongue or for a CA buccal mucosa, and that patient has a very small primary in base of tongue. So patient has a small tumor in base of tongue. I treat that patient with 5 radiation only, 3 to 5 radiation only. That's called a stereotactic body radiotherapy. It's a radiosurgery. It's basically radiosurgery where I give a very high dose of radiation with a precise accuracy.
So for the students, I would also like to mention that this is very important in a oligometastatic lung disease.
Absolutely, sir.
And we have Dr. Kinjal and Dr. Samir's team has treated very nicely few of our patients with a long-term survival in a oligometastatic squamous cell carcinoma head and neck.
So SBRT plays a very good role, like a primary of tongue or primary of oral cavity or a head and neck, having a solitary mets in lung. We do treat this patient with SBRT, where SBRT means radiosurgery. You treat this patient with surgery with radiation. And we give a very high amount of dose in 3 to 5 settings, and we try to cure this. So oligometastasis also is a area where we try to cure these patients with a high dose of radiation. We do it with radiosurgery or we do it with radiofrequency ablation, RFA. For liver, like basically for liver, we do it with RFA or we do it with radiosurgery but we treat this patient with a curative intent. So again a question, what is the difference between SRS and SBRT? SRS is only for brain, SBRT is for the body. They are the same synonyms. For brain we call it SRS, for body we call it SBRT. It's same. Maximum size of mat we can treat with SBRT, no particular size. So even a 5 centimeter tumor can be treated with SBRT. Even a 2 centimeter can be treated with SBRT. So there is no particular site exception where we cannot treat. So we can treat any size, honestly.
And also, if the tumor is 5 centimeter, you treat with one SBRT course,
Yes.
and then you can
So
repeat
a
it
smaller
also.
tumor, yes. So very rightly mentioned by Kaustubh sir, a smaller tumor you tend to treat with sitting. For a larger tumor, you tend to treat it with 5 sittings. So between 1 to 5 sittings, you treat these patients according to the size. I think I missed a lot of questions in between. Proton neutron therapy in head and neck cancer. So proton is good, but it is not the only choice. Neutron, we don't treat patient with neutron. So generally we treat with X-rays, which we routinely do, or we treat with protons. Okay, there is another question. What is the best way to differentiate between oligomet from oral malignancy versus primary lung tumor? Honestly, we cannot judge, because the problem is lung malignancy is also squamous cell carcinoma, head and neck malignancy is also squamous cell carcinoma. So it is very tough for us to differentiate whether it is a second primary, or it's a lung mets. But honestly, if the patient fails within 3 months or 6 months or 8 months, we take it as a mets from head and neck malignancy, oral malignancy. And if a patient fails after 5 years or 2 years or 3 years, we take it as a second malignancy. But we cannot differentiate.
So, as Dr. Kinjal rightly said, there is no sacrosanct way to define it, but when there are some radiological features which can guide you. Usually the metastasis will not have mediastinal or hilar lymphadenopathy. So on your PET scan, if there is only there is a lesion in the lung with hilar and mediastinal nodes, it will tilt more towards lung primary. But if it is only a mat and without any lymph nodal metastasis, it is more towards the oligometastasis. And also the size, and sometimes not only one, you can find 2 or 3. And then you can understand that this is a part of metastasis and not a primary. So there are indirect ways to decide, but there is no 100% way to decide where the biopsy is squamous cell carcinoma. If it is adenocarcinoma or some non-small cell, small cell carcinoma, then it's different. Then you for surely know that this is a new cancer in the lung.
One more question. In IGRT, how frequent imaging is done? It is every day. There was a question from Rakesh. We do imaging every day. So if you call it IGRT, it is every day. We need to see every day, and then we target.
So, and the reason is that the tumor will shrink with radiation, tumor will change its characteristics, and that is the reason why they need to target the tumor in such a way that the normal tissue is not getting affected and only the tumor tissue is getting the true radiation. So that's the reason why they need to image. Dr. Kinjal, can you throw some light regarding PET-CT directed radiation?
Yeah, so PET-CT guided RT, we do it like I showed one slide in my PPT. For tumors, what happens when you do a PET-CT guided planning, there may be some change in the target, because what happens generally, like for all to understand, is that you see a tumor like this, you see a tumor this big, but actual tumor is this much only or this much only. So PET-CT guided RT can definitely be more useful in head and neck for sure, basically for base of tongue, nasopharynx. These are the two sites, nasopharynx and base of tongue. These are the two sites. I would prefer a PET-CT or a MR based planning, because they will exactly tell me the size of the tumor. Sometimes what happens on a CT, so generally when we do radiotherapy planning, we do it on CT. But PET-CT or MRI would make it much better for us for base tongue and nasopharynx. So these are the. I'll not be worried about hypopharynx or larynx. Hypopharynx and larynx can be treated with on CT, but oropharynx and nasopharynx and a PNS tumor. Definitely, Kaustubh sir has rightly mentioned PET-CT based planning is much better, because it will make it much clear to us.
And with an MRI and PET, you will be able to see those perineural invasion going in the foramen, and you can take care of those things.
We have treated patient up to foramen rotundum, sir, and as a curative intent, foramen oval or foramen rotundum, we have treated these patients where we find it on an MR and it is not seen on a CT. So you cannot pick this kind of tumors. Like, so you have a buccal mucosa tumor with a perineal spread. You cannot pick it on CT scan that it is going up to foramen oval or foramen rotundum. So for MR, that is much better.
There is one more question. Cobalt still used in India. Cobalt with MLC also coming. Future of
Cobalt is a old age thing. I saw the question. Cobalt, we have to forget about the cobalt. It has to be linear. Linear accelerator is far better than cobalt. So cobalt is something which is a past thing. It's not a future thing. So we have local Linux. We have a local Linux linear accelerators. Recently, one of that centers started in Ahmedabad and one in Hyderabad. Again, I'm not too sure whether they'll do well or not, but local Linux are also coming up in a big way. Dr. G.K. Rath is our god, honestly. For radiation oncology, he's our god. And according to him, these local Linux are coming in a big way. So I would agree with him, but I have my doubts. But cobalt is out of question. Cobalt is like old days.
So if there are no more questions, I think Kinjal, you excellently described and taught our NB students the role of radiotherapy in head and neck cancer, and we look forward to these kind of interactions with our students on every Saturday morning.
For sure, sir.
Thank you so much, Dr. Kinjal Jani, and over to Navneet Bhai.
Thank you very much, trainees and faculty members, for joining the session. Thank you.
Thank you so much.